So good afternoon, everybody. Welcome to the Health Workforce Council meeting for Santa Cruz County. This is our first council meeting of the year, so thank you for joining us today. For joining us virtually today. We're going to jump right in because we've got a pretty packed agenda with some wonderful presentations today. But before we do that, quickly we'll go to the next slide and ask everybody to introduce yourself via the Zoom. Feel free to input your name, title, organization, and any health workforce projects you're working on in the chat. And while you're doing that, I'm going to quickly go over our agenda for today. So as mentioned, welcome. Thanks for joining us at our first Health Workforce Council meeting of the year. We're going to have some engaging presentations from Garrett Chan with HealthImpact, providing kind of a high-level overview of what HealthImpact is. And then Jasmine and Olga have joined us from PVPSA to share information about their best practices around clinical placement programming. We'll also provide some updates around our Health Workforce Council, all of our work group updates, and some future planning updates. And then we'll share some upcoming events and closing out the meeting, hopefully right on time at 12:30 today. So with that, we're going to jump right in. I'm happy to introduce Garrett Chan with HealthImpact to begin with our presentations. I'm handing it over to you, Garrett. Thanks.
Great. Thank you so much, Haley and Maria, for the invitation. It's great to be here and it's great to see a lot of familiar faces. Hello, I'm zooming in from Los Angeles, although I was born and raised in the Bay Area, so I call the Bay my home. Um, I'm the president and CEO of Health Impact, which is this California Nursing Workforce and Policy Center. And one of our jobs, we have many jobs, but one of the jobs that we focus on is the preparation of nursing students to enter into the profession. And so it was just a pleasure to be asked by Haley and Maria to come and speak about clinical placements and education, not only from, the regional area, where the Santa Cruz Health Improvement Partnership area, but also what is going on statewide. I'm going to go to the next slide, please. Just going to talk a little. I'm sorry, am I advancing the slides? No. Okay, great. Just a little bit about Health Impact. So our vision of the organization, we're a 501c3 nonprofit organization. Our headquarters are in Oakland, California. So our vision is a highly skilled healthcare workforce, optimizing health through innovation, interprofessional leadership, and nursing excellence. And our mission is to shape healthcare through workforce strategy, stakeholder convening, and policy advocacy. And so we've been around since 2001. Our former name was the California Institute for Nursing and Healthcare. And then in 2015, the CEO and the board of directors changed the name to Health Impact to focus more on the health of people living in California as well as people across the United States through nursing. And so that's how we got the name in 2015. And we, on the next slide, do a lot of our work based off of the core values that we have in our organization. So the core values that guide our work and decisions that we make every day to achieve our mission are to create initiatives that ultimately improve health. So not all the things that we do directly have an impact on individuals, families, or community health. However, we have done that in the past and we continue to do so. But that's a smaller part of our portfolio of work. A lot of the work that we do, again, it focuses on nurses and the preparation and the workforce of nurses so that they can actually improve health through their direct care activities. The second core value is to build strategic partnerships through diversity, inclusivity, and equity. We also are courageous in taking strategic risks using scientific evidence to advance a greater good. And then the fourth value statement we have is to empower staff, partners, and the communities to make changes in the world. We've California is a very large state, as all of you know. It's kind of interesting to hear my colleagues in other state nursing workforce centers across the US when they say, oh, in New Jersey, we did this statewide initiative. And I'm like, wow, that's amazing. You got a statewide initiative off the ground. And then I had to Google to see that you can actually fit 21 New Jerseys into California. So 106 Rhode Islands, by the way. uh, uh, California is really regionally focused, and we honor and respect that, as well as work on things that really affect the entire state. So on the next slide, when I first got into my job here at HealthImpact, I was formerly at Stanford Healthcare, and I held several senior nurse executive roles. Um, I was really excited to do something outside the four walls of a single institution. And they say, congratulations, you're now the president and CEO of this nursing workforce center. And I'm like, great, I'm excited. What does that actually mean to be over a workforce? And so I worked with my board of directors to come up with this infographic to share with you the kind of seven key priority areas of workforce strategy that we've identified in California. Um, so on the very left, we start with the K through 12 system. So how do we sensitize, energize students in the K through 12 system to consider any health profession, and specifically nursing? And how do we create programs within K through 12 systems to accelerate entrance into the health professions? People may know that there are 8 high schools in California, among the hundreds of high schools that we have in California, that are either specifically designated as health sciences high schools, or they have a pretty strong academy of health sciences located within the high school itself, which is really exciting. And again, 8 out of hundreds and hundreds of high schools is a start, but definitely there's areas for improvement and more growth. The second key priority area for our workforce strategy is in the prerequisite education and pre-nursing pathways. We're working on a project right now, trying to finish this up by end of April, where we looked at the 160 schools of nursing pre-licensure RN programs in California. And we've cataloged every single prerequisite that every single program has. And I will tell you, there is absolutely zero commonality. And so what does this mean? This means that people who are interested in nursing as a career pathway, they are going to have a hard time having all of their core prerequisites that they need to enter multiple schools. Every school is different, and each of the prerequisites are different. And so there's a lot of what we have found is that there are a lot of students who are thinking about nursing as a pathway, where they're trying to juggle the requirements from multiple schools. And so there's this huge credit burden that these students are taking. They're also using a lot of financial aid dollars to get through the prerequisites, and which actually has an impact on their trajectory within nursing school, because they may run out of money or eligibility for funding. And also, they also are taking classes that may not even um, be able to be applied if they want to go on for their bachelor's degree, because the course that they took in a particular, let's say, community college, does not meet the general education requirements or standards for that course to be applied. So they have to take another course to get in to or for their bachelor's degree. So we're looking at that, trying to figure these things out, trying to make it visible so that people understand, what are some of the challenges in the prerequisite domain to get into nursing school. We're also looking at pre-nursing pathways. So we do in California, we do a very good job in educating and making available funding for people to become certified nursing assistants or community health workers. The California government 2 years ago invested $25 million in increasing the number of certified nursing assistants, home health aides, and community health workers. And that's great. We need to have them. They're incredibly valuable. And yet we don't actually have a good pathway for them to go from that um, career job, if you will, into nursing. And so we're trying to think about how to smooth those pathways so that they can continue to go on into nursing programs. The third key area is in our pre-licensure education at the registered nurse and the advanced practice registered nurse levels. So the registered nurse level, of course, everybody knows what that looks like. The advanced practice registered nurse is an umbrella term that is used to include different roles in nursing, such as nurse practitioners, certified nurse midwives, certified registered nurse anesthetists, and clinical nurse specialists. So these are the four roles that are direct care roles at the advanced practice level at a graduate degree. So you must have at least a master's degree or possibly a doctoral degree, depending on which school you decide to go to. And so we also are concerned about the pre-licensure education for advanced practice registered nurses as well as registered nurses. And today's talk is going to be really in this domain because we're going to talk about the importance and the reasons why we have clinical education as part of our um, educational programming so that people can become an RN or an advanced practice registered nurse. So we know that most nursing students graduate. We do have about a 9% attrition rate. We admit about 13,000 nursing students into schools of pre-licensure RN programs in California per year. We know that we lose about 9%, and so that's an area that we're also starting to do some work on is why are we losing 9%, which is equals to about, a little close to 1,000 nursing students a year. So if we're thinking about workforce, it's like, well, there are some people who actually will not be good nurses. There are safety concerns, and so we expect that there will be some attrition, and that's okay. But what are other things that we can look at in terms of the 9% kind of across the state as an average to think about how do we shore up and support those nurses who actually did everything they could, and they also got into a nursing program, and then they leave the program or they are significantly delayed in their program. And so thinking about how to actually support that population is something that we're starting to work on as well. You have to pass a national board exam called the NCLEX to become a registered nurse. So if you are, again, lucky enough to pass the NCLEX, and you can take it as many times as you want until you pass, then you kind of cross over the Golden Gate Bridge into the workforce side of our infographic. And on the workforce side, we have upskilling the workforce through academics and mentoring programs. Those are kind of transition to practice or apprenticeship programs. We're looking at innovative models of care delivery, the advent or the ascendancy of artificial intelligence, the concern that people have in terms of, and the growth of virtual care, and what does that mean for the workforce. Kind of at the 11 o'clock position, we're looking at retention, health, and well-being. We know that anywhere between 18 and 34% of new grads leave direct care nursing, or they leave the profession entirely within the first 3 years after graduation. So now we have a sieve on the other side. And so how do we kind of plug those holes, if you will, so that we don't lose people because they've spent tons of resources to get into nursing school, graduate, and we need to keep them in direct care positions. So what are the things that we can do to help improve that? And then the seventh is workforce migration. We see that a lot of nursing students graduate from metro areas like the Bay Area, Los Angeles, Orange County, San Diego. They can't find a job, so they move to the far north, the Central Valley, Central Coast, Inland Empire. They work for 1 to 2 years, then they become experienced and they move back to the metro areas, which creates great instability for those parts of California where they're trying to establish a workforce for high quality and safe patient care. So those are the 7 areas of health impact, and I'm going to now kind of focus in on the pre-licensure education space because we're going to talk about clinical placements. So on the next slide. This is a model that I've recently come up with, not yet published, but I'm working on a manuscript right now, talking about the issues that we see in current state and where we need to be as a profession, and trying to bridge what's known as the academic practice gap. There's a gap between what is taught in education and what nurses need to be prepared to do and how they can function in the practice setting. So on the top box, we have so the dashed line is a time marker, which is graduation. So on the top box, what we see is that there's a lot of direct clinical practice education, some systems practice education like leadership, evidence-based practice, research, etc. Um, and when they graduate, it's incumbent on the practice agencies to do these transition to practice programs, residencies, fellowships, apprenticeships, to get them to where we need them to be in terms of the practice of nursing. And really, what we need to do is, and I'll just tell you, when I was at Stanford and I had 56 new grads per year, I calculated the cost of the new grad program to the organization, and it cost $1.9 million for me to run a transition to practice program for 56 new grads. I calculated everything. I calculated the first 2 weeks that they're on the unit with their preceptor, we cut their preceptor's assignment in half. So they would only take half of the assignment. So what that meant was that we needed to bring another nurse in to take the other half. So I counted those dollars and hours. I counted my staff, my clinical educator hours, all the time that the new grads were spending outside of the direct patient care settings. I calculated all the subscriptions that we would provide, and it cost $1.9 million. So there's a rough estimate at UCLA. They have about 100 new grads a year. It costs them approximately, and this is probably a conservative number, $10 million a year. So there's great cost, and it's an unfunded mandate. There's no reimbursement for clinical agencies to recoup those costs, at least not currently. There was one system that is looking and has been able to figure out a way to get some monies out of the Centers for Medicaid and Medicare Services, but it's not widespread, and we're still trying to figure out if it's applicable to everyone. So there's a lot of costs. And the other thing that we know is that there is burnout. And again, not being prepared to pick up the practice of nursing is one of the contributing factors for new nurses leaving the profession or their jobs within the first 3 years. So how do we solve this? Well, we need to push, their preparation for the practice of nursing much farther upstream, and working with academic institutions to provide, meaningful direct clinical practice education, do some systems practice education so that we just kind of finish things off after they graduate, as opposed to giving them the majority of what they need to know in a very short amount of time. So on the next slide, I just wanted to share with the group, that we in nursing don't have kind of a shared understanding of what is the purpose of clinical education. In other health professions, it's much more clear. In nursing, we have a wide variety of beliefs and perspectives, and I do value diversity without question. That is not a concern that I have. We as a profession are not we don't are not even in the general vicinity with each other. And so a lot of the work that we're doing at Health Impact is to really talk and create clarity and a shared understanding of this term, clinical education. So I'm going to pause for a moment and just do a very quick uh, activity with you all. So I'm going to say a word, and I want you to picture this word in your mind. Okay. So I'm going to say the word is chair. So think of a chair in your mind. Now, if I were to tell you that my chair is brown, it's squat, it looks like something that you might see in, for those people who know Goldilocks and the Three Bears. It's like the little baby bear's chair, with a little high back and dowels. And it sits about maybe 36 inches off the ground. Is that the same chair that you have in your mind? Probably not. Probably not. But yet the word chair is very common. We use the word chair all the time, but every one of us has a different perspective of what that means. Um, some people may even think of a chair of a department, so they may think it's a person, right? So, and not a piece of furniture. So, what we're trying to do at Health Impact and what we are doing is really having people understand what is the purpose of clinical education. So, when we say the term clinical education, what does that mean? And so, this is based off of scientific literature. So, this is not something that we've made up kind of in our heads, but the literature, some literature says that the central purpose of clinical education is to move learners from seeing the clinical world as being elemental, partial, and dominated by task and procedure. So elemental meaning like in its elements, like this element, that element. Partial, so I only have to see a piece of this pie or the piece of the picture. So we need to move them from that to engaging with the clinical world as a nurse to see meaningful clinical patterns and an increased understanding of the whole patient, family, or community situation. So this is why we need people in clinical practice, is to move them from seeing these partial elemental pieces to actually seeing a whole clinical picture. And that takes time. It takes a lot of exposure and a lot of experiential or experiences to get them to be able to do that. And this is why we have clinical education in nursing. On the next slide, I'm going to talk about kind of on the bottom, and I'm sorry it's a little small, but I'll just read it through with you, is to develop a perceptual grasp. So being able to understand what's going on in the situation, they walk into the room and they're able to sort out what is important, what's not important. The second is to understand notions of the good internal to the profession and develop advocacy skills, because that's what we need nurses to do. We need nurses to respect humanity and open up social spaces to develop skills of involvement and relationship building. And we need to develop clinical competencies. And you see the 9 clinical work role competencies. So on the next slide, what I'm going to just kind of go over with you is some of the uh, issues that we see in nursing education. We can use both inpatient or in-person experiences, but we can also use simulation. We need about there's about 870 hours of clinical education that needs to be is a minimum according to the Board of Registered Nursing, with 500 of those 870 clinical hours as in direct patient care. And each of the 5 areas, medical, surgical, pediatrics, labor and delivery, OB, and psych mental health, we need 30 hours of direct clinical care as a minimum. And the remainder can be in simulation. Just as a note, clinical placements may not be paid for. It's a prohibition. There's a law that prohibits that. On the next slide, um, I'm gonna just share with you some of our what we see kind of in different parts of California, including the Central Coast here. At the local level, there are challenges around educational agreements. All the academic institutions must have a contract with clinical agencies to place students, so that takes a lot of time, effort. Um, Stability in clinical placements over time. So there are some clinical institutions that can take students sometimes, but not other times. And so that instability creates challenges. And this is not an exhaustive list. This is a list for us to discuss today. There's a logistics tangle in managing clinical placement. So some places use emails and an Excel spreadsheet or paper and pen. Some use a software like the centralized clinical placement system, or some people might have heard My Clinical Exchange. So those are some of the local challenges in clinical placement. Some of the regional challenges that we see is bringing together consortia or groups of people together to actually work through these issues. There are 8 formal large regional consortia in California. Um, and then we have these networks of individual academic institutions working with clinical agencies. There's a lack of transparency of clinical availability in a region so that people can see what's available and what's not. And then these regional consortia oftentimes work on policy issues like onboarding issues. Every clinical institution has a different onboarding process. So how do we streamline that? How do we look at curricula? Because every school has a different curriculum. And so how do we understand on the clinical side what is expected of these students, and also faculty shortages? And then at the state level, we need better understanding of local and regional surplus and deficits in clinical placements. And I see Nanette Solvenson here is here. She's awesome. I put in this, she did a phenomenal webinar last year in December, on December 13th, and there's the link. And my slides are freely available. If you can send them out, that would be great. You can just click on the link and you can see the fantastic webinar that Nanette put together for clinical placements if you want to learn more about that. And then the last slide that I have is preceptors. I just want to make a note about preceptors. We couldn't do clinical education without preceptors. There is an article that I wrote, and it was published earlier this year, about the challenges and issues and potential solutions for preceptors, because that is oftentimes a rate limiting factor. We don't always have qualified preceptors, so we have a loss of experienced nurses in direct care positions, and so we're seeing a significant increase in the number of nurses who are 1 to 2 years out of their schooling being the preceptors, which creates challenges. Um, there is a lot of burnout and moral injury of clinical nurses, direct care nurses, and so they don't feel like they can take on a nursing student because it can, take up a lot of time. They also are seen as expert nurses, and so we believe that the practice of teaching is different than the practice of nursing. And so these preceptors are not really educated in the practice of teaching. And so they rely on something called see one, do one, teach one, which is never the right way to go, unfortunately, to learning the practice of nursing. And so we don't get the best educational experiences out of these precepted time with their preceptors. And as I mentioned earlier, precepting nurses is an unfunded mandate, unlike graduate medical education. So for physicians, the Centers for Medicaid Medicare Services in 2022 paid out $22 billion with a B for graduate medical education. And nursing gets, maybe $500,000. And that's just for academic institutions. It's not to clinical agencies to help offset the costs But we're looking into that. There is a recent paper that has examined that to see if there's ways to get money to help with the costs. So that's the end of my presentation. I know I went through a lot. I talked a lot. So I
Lots to
don't know, Haley,
cover. Yeah.
is there time for questions or do we
We
move on?
don't have time for
Okay.
questions. However, attendees are welcome to put any questions in the chat. And also, Garrett, if you're willing to share your information in the chat or respond to questions, we do want to make sure we have enough time for our next presentation. So we're going to go ahead and Olga, you want to screen share your slides. So Maria, you can end screen share. And so yes, we are going to quickly transition. And I'd like to introduce you all to, I hope I don't butcher your last name. Olga Rechetova with PVPSA is going to share with us best practices in clinical supervision. Great, your slides look great. We can see everything. So I'm going to pass it over to Olga. And if you have questions for Garrett, please put them in the chat. Thank you,
Perfect.
Garrett, and thank you, Olga.
Haley, you did great with my last name, by the way.
Oh, good.
Hi, everybody. I'm Olga Reshetova. I am a licensed clinical social worker, and I'm joining you from PVPSA. With me today is Jasmine Nahera, our CEO. And so Jasmine will just introduce our agency briefly, talk a little bit about the work we do, and then I'm going to transition into talking about our clinical placements.
Good morning, everybody. Good to see folks. We're happy to be here today, and I'm super excited for you all to get to learn from Olga, kind of our best practices around clinical supervision. Just wanted to share a little bit about Pajaro Valley Prevention and Student Assistance. Our mission is to improve the quality of life for children, youth, and families by providing mental health, substance use, and prevention services. And we advocate for public policies that protect and advance the health and well-being of the community. Next slide. PVPSA, I've been here for about 2.5 years, and I've really been working with Olga and our team to uplift that we are a workforce development agency and have a lot of opportunities. So we've established really strong partnerships with local universities and beyond. In the past 3 decades, we've provided over 300 master's level graduate students with clinical internship opportunities. We created pathways for community members to become licensed behavioral health providers locally, offering employment opportunities with potential growth. We support our staff with financial benefits, including student loan repayment, recruitment and retention funds, and bonuses for employees who've been here for 5 or more years. And we're really focused on growing and supporting our own workforce locally. That's one of the best ways that we've been able to fill positions. Go ahead. And so then I'm going to leave it in Olga's hands. She oversees all of our clinical placements and partnerships with the universities. She's done an amazing job running this program, and we hear excellent feedback from our interns all the time. So go ahead, Olga. Thank you.
And before I jump into this, I'll just share briefly about my own clinical process. So I got my master's in social work in 2013. I joined PVPSA in 2016, got my license in social work, and began supervising both interns and associates. And that feels important to share because I've been on all, I've been a part of every step of this process. I've been an intern myself. I've been in supervision with a variety of supervisors, some amazing, some not so great. And then I've also had a chance to be a supervisor myself. And I am still learning with every intern I get, with every cohort or graduating class. There's something that I get to learn from them. And this presentation is just sharing the things that we have learned so far, the things that we know work well in this field in general, and the things that work really well for us. And like Jasmine was mentioning, here at PVPSA, we're really committed to supporting our clinicians, our new clinicians at every step of their journeys. So the first step of that journey is usually when clinicians are just starting graduate school. when they're going to get their master's in social work or marriage and family therapy. And as part of that program, they need to complete a practicum. And so they come to us, they come to our agency for their practicum. And we have a designated practicum program for them to join. They start with us in August and they start together as a cohort. So they all meet together for orientation and they move through that school year together. We work with kids and adolescents. We do a lot of school-based work. So these interns get placed at a school site, and that school site becomes sort of their home base. And when we get these brand new interns that are just doing this for the first time, we really treat them as learners. We expect that they don't know what they don't know. And everything they do, every step of the process, we guide them through it. So in this traditional practicum program, they really get a lot of support, a lot of hand-holding. We teach them everything from, how do you pick up a phone and call the parent of your client for the very first time and explain to this parent why their child was referred to counseling. How do you handle that initial conversation? What do you do in the initial session with your client? How do you document that session? What do you put in your notes? So there's really a lot of guidance through every step of that process. And these interns typically serve clients that are considered to be low to moderate level of need. So we don't throw them right into the deep end. We give them clients that are in need of support, in need of services, but maybe not our highest need clients. And then sometimes we get applicants for internship that bring in a little bit more experience with them. Maybe they've had a year of clinical experience somewhere else, or, and this is, especially an exciting moment for us, or sometimes we have our own staff members that were working in a different role here at the agency, and then they got inspired, they wanted to go back to grad school. Now they have to do their practicum, and they get to stay with us and do something that we refer to as employment-based practicum. So it's still an internship for them. It's still a practicum for them. They're still learners getting a lot of support, but it is also their job. And, just on the practical side, it is really cool that we can offer it to them because most practicums are not paid. And this way they can retain their salary, their benefits, their job security, and still have this learning experience. Because these interns are coming in with more experience, they typically have higher need clients. We may have higher expectations for them in terms of paperwork, timeliness, and productivity, but we continue to provide them with the same level of support as our brand new interns. And then the next step to this journey is when somebody gets their master's, they register with the Board of Behavioral Sciences as an associate social worker or associate marriage and family therapist, and they start the lengthy process of getting their hours towards clinical licensure. And at that point, they continue to stay in supervision. The board requires for them to get supervision, and we provide that here at the agency. These clinicians typically hold our highest need clients or on the higher end of the spectrum. We do have requirements for them to comply with in terms of paperwork and documentation timelines. They function with more independence and autonomy, and they have a little bit more certainty in themselves. And they continue to receive supervision support and also clinical training, because at this stage is when they really start to figure out what is maybe a specialty that they want to concentrate on, what is something, a modality, an approach that they really want to learn. And so they might pursue an advanced clinical training in that. And the last step of this is when somebody gets their license, they pass their licensing exam, they get all the clinical hours, they become a licensed clinical social worker or LMFT or LPCT, and they stay with us, hopefully. They continue to provide care to their clients, but they also take on a supervisory role. They become a clinical supervisor or a mentor to new clinicians. And at that point, they receive not so much supervision, but more consultation from somebody about their cases, because everybody who works with clients, regardless of how experienced they are, best clinical practices for them to still receive consultation from somebody. They continue their clinical training, and they also get something that we call supervision or support for supervisors. So that's their space to talk to somebody about what is it like to now be in this supervisory role, to hold this position of power and knowledge, and talk about some of the challenges that might be coming up with their interns or supervisees. But what is actual clinical supervision? What does that mean, and what does that look like? The Board of Behavioral Sciences requires that everybody who is not licensed receives clinical supervision from a qualified licensed supervisor. And the purpose of this clinical supervision is to really ensure the quality of the work that they do with clients. As supervisors, we are responsible for client care of the clients that our supervisees serve. So we really monitor closely what happens in sessions. What interventions are we using? Are we following legal and ethical requirements? Is this case appropriate for the intern's level of knowledge and expertise? And how are they feeling with it? Are they getting enough support with this? Because this is something that is required by the board has pretty strict and specific rules for how much supervision each person needs to receive at each step of their journey. So 1 unit of supervision is described as either 1 hour of individual or triadic supervision. Triadic supervision is 2 supervisees per 1 supervisor, or 2 hours of group supervision. And again, very explicit rules dictate that a group must be no more than 8 supervisees for 2 hours, just to make sure that everybody gets enough time. Those that are still in school to get their master's in marriage and family therapy must receive 1 unit of supervision for every direct client hours. And once they get their master's and become associates, that ratio switches to 1 unit of supervision for every 10 client hours. And for our social work students, there's actually no ratio to follow in terms of client hours, but every week they must receive at least an hour of individual supervision with an MSW who's 2 years post-master's. So what that means for us as an agency that's, not huge, somewhat small in size, what that means for us is whenever something happens, somebody is sick or takes vacation, if I need to take some time off, I think about my supervisees and are they going to get the supervision that they need to count the hours for the board, for their licensure. And we must monitor that very carefully and make sure that there's always coverage because we don't want them to lose their hours that they've been working on. And also we want to make sure that they're getting support and oversight for every week when they're doing direct work with clients. Again, the BBS is very specific about what qualifies somebody to be a supervisor. That person must be licensed in one of these specialties. That person must be licensed for at least 2 years. So we get really excited when one of our staff clinicians gets licensed, and then I'm like, okay, so counts down. In 2 years, we'll get you as a supervisor. And it is really important that the supervisor does some kind of direct practice for at least 2 years in the last 5 years. So either they're seeing clients themselves or they're doing supervision, clinical supervision with others. And there are requirements about continuing education that they need to complete to be a supervisor. And this is, we're getting more into the fun part of what actually happens in clinical supervision. What does that look like? What does it feel like? When we're meeting with somebody, our supervisee, let's say it's maybe individual supervision, we're meeting for an hour privately, it's their protected time. We spend a lot of time talking about their clients, about the sessions they're having, about cases that they see, and ideally, if there's any high-risk situations, we start with that. I teach and train my supervisees that if there's something super pressing, really serious, concerning, safety concern, to bring it up first, because we can't spend an hour talking about fun art therapy interventions. And then at the end, they say, oh, there's a CPS report I need to make, and it's 5 o'clock. So I really, encourage them not to be the doorknob client, right? The doorknob client is the client whose hand is on the doorknob. And as they're leading the session with the therapist, they say, oh, by the way, here's this big thing. So we start with those high risk situations. For CPS reports, it's something that I monitor very closely, and especially if it's their very first time doing that and it feels scary and intimidating and that brings up all kinds of, anxiety and fear. We usually write that report together. We might make that first phone call together. And then we also take some time to process what is it like for you to call this big system, to share this information about your client. What was it like for you to hear that maybe there's some abuse or neglect happening with your client? So providing some support on that. If there is suicidal or self-harm ideation, again, that comes first. We need to process that first, assess for safety, and guide them on the next steps that they need to follow. But once we get through these high-risk situations, that's when we can really dive deeper into the clinical work that they do with their clients. That's when we can really take the time to reflect on what's happening in the session. What interventions did you use? What was it like for the client? What did you notice? What came up for you? I love it when my supervisees bring me client artwork or pictures of a sand tray that a client did, and we can just really nerd out together and look at that and go deeper with them. In supervision, we do also cover legal and ethical requirements, confidentiality. Dual relationships are pretty big for us because we're lucky that a lot of our supervisees and staff clinicians live here in Watsonville. They come from this community. They grew up here. They went to these schools. But the challenge is that they have a lot of relationships with community members. And oftentimes they might say, I know this client, I know this family. This is my, husband's cousin or somebody. And if it's not directly their client, sometimes they might know a client that a fellow intern is talking about in group supervision. And that's when we need to say, okay, pause, let's reflect. What's your relationship with this client? What do you know? How close are you with this family? Okay, let's make a plan. And oftentimes the plan is, okay, we're not going to talk about this case in a group setting. This is something that the other person can discuss with us individually. But then the intern who does have that relationship with them is not around to hear that, just to protect that confidentiality piece. As a supervisor, we're also serving as administrators. So we track the caseloads of our supervisees. We see which clients are ready to discharge, which new clients are coming in. We're checking in if tasks are completed, if paperwork is done. So there's this admin component to this. We do a lot of teaching. We teach them what interventions they can use, what's an appropriate modality. I really try to make sure that every supervision, somebody leaves with something concrete, that they're holding either an intervention, an activity, a worksheet, a book, or just even a phrase that they can use for their clients so that they have something tangible to hold on to and use in their next sessions. We review their clinical documentation. We talk about the context of the work that they do, both in reference to the dynamics of our agency and also the school site where they're placed. What's coming up there? What are the challenges? And the challenge could be somebody keeps coming into my counseling room, and as soon as I get my client to open up, somebody barges in and I lose all progress I made. Or it could be something a little bit deeper, but we really take the time to process what is the environment in which they're doing this clinical work. We talk about their university requirements. Sometimes we need to sign off on university assignments and on PBS paperwork for their hours. We take the time to provide them feedback and do formal evaluations. And when we're evaluating supervisees, to me, that's really an opportunity to ask for some feedback in return, to ask, how is this feeling for you? Is this working for you? What is your learning style? Is there something you would like us to do differently in supervision so that it is more of a reciprocal conversation? We provide a lot of emotional support. This field can lead to a lot of burnout, to vicarious trauma. And we hold space for that, and we monitor closely how are they doing, not just as clinicians, but just as people doing this really hard work. We create space for them to reflect on their personal biases, the feelings that are coming up for them, their own values, their own family structure, just anything about their identity that is affecting their work with clients. And this last point is, it's coming up a lot right now because we're at the end of the school year. We have these interns that are preparing to graduate or go somewhere else, and they're really thinking about what's next for them. And so we take the time to process, what do you want to be when you grow up? What kind of role do you want to have? I share a little bit about my experiences, my journey, and really try to guide them on figuring out the next steps in their career. So that is a lot that happens in just that hour of supervision, and usually it's not all of those things. But I think that's what makes this relationship so unique, because as a clinical supervisor, you are a teacher and a mentor and a cheerleader, and then also an authority figure who sets boundaries and holds them accountable. And then also somebody who goes deeper and who holds space to process some of their personal stuff, and sort of like a therapist. And so you are all of those things, and you're none of those things individually, and especially not the therapist, even though that can feel a little slippery. But holding that boundary is really important. So having this relationship with our interns and our staff clinicians feels like a really unique relationship. I haven't experienced it anywhere else, because you're a little bit of everything, and you're also none of those things. And there's personal sharing, and then there's also the power dynamic. And that's why it feels important to be really mindful of how we handle these relationships. So these are some of the models that we use at PVPSA. The developmental model speaks a lot to me because I work with kids myself, and so that just makes a lot of sense. And when we think about kids, we know that they go through various developmental stages, and with each stage, they reach certain milestones. And as adults and caregivers, we need to give them different kinds of support during each of those stages. So with babies, their main question, if we think about Erickson's stages of development, with babies, their main question is, can I trust the world? Will I be taken care of? Will my needs be met? Will I be safe? Will I be fed? Will I be nurtured? And so then caregivers need to give the message that I got you. I'm going to keep you safe. I'm going to take care of you. I'm going to meet all of your needs. I'm going to feed you and nurture you, and I'll be there for you. And then as kids get a little bit older and they become toddlers and preschoolers, and they move around and they have all of these new abilities in their body, and they can run fast and they can climb on things, their question becomes, can I trust myself? And then caregivers need to give feedback that you can trust yourself, because wow, look how much you can do. You can run so fast and you can jump so high. Look what you can do. And this is similar to our supervisees. When they come in as new interns, they're full of questions. They need a lot of reassurance. They need that sense of safety and security. And they need to know that as supervisors, we're going to be there to meet their needs. And then as they get a little bit more confident in their abilities and their skills, it shifts to thinking about, okay, what can I do? Can I do this intervention? Can I try that? Can I try working with this population, with this client? And then as supervisors, again, we reassure them that you can do this. Look what you can do. Look how much you can do. This is something that's important for me to remember when I get brand new interns, and they're walking around all day, and they get more and more questions about this role, about the clients, about the work that they need to do. And then they come to me and they're full of questions. They really need answers. And I tend to lean more into like a reflective side of things. And sometimes my answer to them is, it depends. It's case by case. What do you think about this? And it is so hard for these interns to hear this answer, because they really need a concrete plan of action. And so I've learned to shift and to say, I'll give you an answer, I will guide you to your next step, but maybe let's reflect on this a little bit, but I will give you the answer and reassurance that you're looking for. And then when somebody becomes more experienced and maybe even licensed, we really spend a lot of time reflecting and not really giving specific answers, but more so diving deeper and analyzing what's happening so their needs really shift. And something that's kind of cool is when a supervisee is learning a new modality, working with a new population, they kind of revert back to a lower level. They become less experienced in the specific modality, and they continue to need more support, even though maybe they're really experienced in a different modality. Okay, so another model that feels really important to follow here is reflective and trauma-informed supervision. And this really acknowledges that stress and trauma can be caused by a variety of things in this field. It can be caused by direct clinical work, especially if there is a case that feels really heavy, really traumatic, or if it's a case that maybe triggers a personal experience that a clinician had in their own life. Stress and trauma can also be caused by workplace dynamics, what happens here at the agency or the school site, and it can also be caused by personal experiences that clinicians have had outside of here. There's an expression, the wounded healer, and it feels true because a lot of people enter this field after they've had their own lived experience with their families, with themselves. Maybe there's a history of trauma from childhood or later in their life, and then they enter this field really wanting to help people, but that story is still there, and sometimes it comes up when they start doing work with clients, and it comes up a lot when they start doing work with kids. I think work with kids really brings back their own childhood stuff, and so just being aware of that, acknowledging that, and holding space for that is important. I tend to check with my supervisees about their level of comfort with a specific case if I know it's going to trigger a personal experience. So grief and loss is a common example because it's something that's so universal. And we get a lot of cases when a young child is dealing with grief and loss. And if I know my supervisee had a recent experience with that, I tend to check and see how would it be for you to hold this client. Let's talk about this before we move forward, just to make sure that it's going to be okay, that it's going to be a supportive experience for them. Thinking about the trauma-informed model, we also need to be aware of establishing really clear expectations for our relationship, because clear expectations and boundaries help people feel safe. When they know what to expect, when they know what to depend on, they feel kind of reassured. And this also means addressing the fact that there is a power dynamic in this relationship. Whenever there is a course I take on supervision, the power dynamic is usually mentioned, and usually the right answer is you need to talk about the power dynamic. You need to bring it up with your staff, with your interns, with your supervisees. You need to name it. This is something that's really important to acknowledge. And none of these courses tell us how to acknowledge it. So I always have this feeling of like, okay, this is really important, and what do I do with this? So typically I start this from the beginning when we talk with new interns and new staff about what is clinical supervision, what is it going to look like, what is it going to feel like, and I just let them know that, I think I'm really fun and easy to hang out with and really funny, and there's a power dynamic here because I tell you what to do, I write your evaluations, I assign you tasks, I approve your time off, and I'm aware that it's there and it might impact our relationship. And let's talk about what to do with this power dynamic and how can this feel a little bit safer for you? How can we make sure that there is still trust here? And the last point here is, again, being really mindful that supervision does not shift into personal therapy for the supervisees, because as I mentioned, they hold a lot of things, a lot of personal feelings. They might have a reaction to a case or just a stressor in their own life, and it can feel really easy to shift into just supporting them. And we do it to an extent, but then we need to circle it back to the clients, to the clinical work. We need to ask, how is this impacting your ability to be here? What was it like for you to be with your clients today when you're holding your own story? So redirecting back to the clinical work, and also exploring if maybe they would benefit from getting outside support from a therapist or somebody outside of the agency, somebody who's not their supervisor. I think every school year, at least one of my supervisees ends up going into therapy, partially as a result of personal things coming up through this work, and with some very, gentle encouragement from me when I realized that I can't be that person for them, and they need that person in order to be effective and successful in this field. And then the parallel process is something that I think is just really cool when it happens in supervision. And the idea is that when a clinician works with a client and then they come in to meet with their supervisor, unconsciously they say things and they do things and they feel things that really resemble what it's like to be their client. So the way it might come up, and sometimes I might prompt it to, if I have a feeling it's there, it's coming. I might ask them, hey, this case is really hard. You're trying all these things. They don't seem to be working. How are you feeling? What's coming up for you right there? And then they might say, I don't even know what to do. I'm helpless. I'm not good enough. I'll never be able to accomplish anything here. The clinicians say that, but, my adult interns say that. And then I might say, do you think this is how your client feels in that situation? And it's really cool when there is this aha moment and they realize that the words they're saying are actually their client's words. It's their client's feelings. And then for me, as a supervisor, I give them feedback or interventions or reframes that they can then take back to their client and apply them in their session. So it kind of creates an opportunity to really model for them what it's like to hold space for somebody who's dealing with those things. I remember on my end, when I was a clinician working with a client who I really struggled with, and I didn't know what to do, and I kept coming to my supervisor and saying, I've tried everything, I don't know what to do, nothing seems to be working. And at one point, he kind of acknowledged that the way I feel about my client, that I just try all these things and I can't help them. That's how he feels when I come to him and I say, help me. And he tries to help, but he feels helpless because none of those things seem to be working. And I remember this realization that there is this parallel process. And the feeling I get is the feeling that the supervisor gets. And I remember asking him, well, then, what do you do with these feelings? And he was kind of like, well, that's for me and my therapist. Then I go on to the next level and then I process it on my own, right? Because there's always this ladder that we have. And that is the parallel process. And then in terms of the PVPSA process, as I mentioned, when we get new interns, we start with orientation when they come in together as a cohort, and they really form these networks, these learning communities. So group supervision is something that we offer them, and it's one of my favorite parts because they get to learn from each other as much as they get to learn from me. They get to follow each other's cases. They get to just develop these relationships with other people that are doing similar work, because nobody else fully gets what it's like to do this work. And these relationships with other professionals in the field become really important. So creating learning communities, giving them a lot of support and time and attention in the beginning when they most need it feels really important. Something else that we offer is we have multiple supervisors on staff, and our supervisors are different from each other. They have different approaches, different styles, different theoretical orientations, and sometimes clinicians can choose which orientation they would benefit from and who do they want to work with. And as supervisors, we also collaborate on cases. And for our clients, that means that they're getting so many different perspectives on what's going to serve them best. And for supervisors, it means that we also get peer support from each other. We're not holding this on our own, but we can talk to a fellow supervisor and get another opinion. Sometimes we disagree on what to do. And usually it's not related to anything big, but more so like what specific modality should we use here? What is the intervention that we want to take? And we're really open with our supervisees about that. And we let them know that if you ever get different feedback from two different people, please let us know. And we're going to talk to each other and we're going to figure it out and we'll give you a course of action. But we don't want them to feel like they're stuck in the middle and they have to choose. It's on us to have these conversations with each other and to come to an agreement. We do a lot of hands-on learning. We give a chance to our supervisees to shadow others. We love coming into their sessions, either to observe or to join and to co-facilitate. And they really get to learn from seeing something happening live, as opposed to reading about it in an article or watching a video about this. Something that also feels really important, just to me personally, is that all of our supervisors do direct practice. All of our supervisors are seeing clients. We hold our own caseloads, and that means that we get it. We know what it's like to run from school to school, to see a lot of clients, to catch up on your notes, and we also get to use our own case examples for teaching purposes. And my interns love it when I bring up like, oh, I had a client just yesterday who was throwing a tantrum in my office and I was struggling. They just like really crave those stories. Sometimes I might send them examples of my notes. I might tell them about my session and I say, here's how I documented this. So they just really like learning from that. And lastly, what we do is we ask for feedback. We ask for feedback directly, like, hey, is this working for you? What would you like for us to do differently? How can we shift? And we also send out anonymous surveys so that people can provide feedback about their supervisor, about their triadic partner, so the other person who's in the group with them, and just about anything else that they might want to get from supervision in a way that feels a little bit safer if it's anonymous. Right, and got stuck on the slide. Okay. So another factor that is really important to acknowledge is that we all hold these different identities. We carry them with us. We carry them into the sessions with our clients, and we carry them into supervision. Our race, our culture, ethnicity, age, gender identity, our family status, our work title, and lots of other things that make us who we are and that are there present in the room because we don't operate as blank slates. And it comes up in client sessions and it comes up in supervision as well. Something that's been coming up recently is the fact that we're working with a lot of Hispanic families. We're working with a lot of monolingual Spanish-speaking clients, a lot of first-generation immigrants, and we're lucky that a lot of our clinicians resemble the population that they serve. A lot of our clinicians are also bilingual in Spanish and bicultural, and they really relate to their clients. And at the same time, a lot of our supervisors are different. A lot of our supervisors are white. Maybe they don't speak Spanish. And so that creates a bit of a disconnect between the clients and the clinicians and the supervisors. And we've been trying to really think about it carefully and reflect on how is this serving our clinicians? What challenges does it create for our clinicians? And what can we do differently? We've contracted with outside professionals both clinicians and other professionals in the field that are people of color, that are bilingual, to bridge this gap a little bit, to give our staff an opportunity to receive supervision from somebody who is bilingual in Spanish, who is bicultural. And we've created some peer support groups here at the agency that is specifically aimed at talking about these issues and creating a safe space for supervisees, for any clinicians really, to reflect on what is it like for them to do this work and how does culture come up there. And another situation in which this might come up is when we work with somebody who is similar to us, who is coming from a similar culture, similar ethnicity, who holds some of those similar experiences. And I know for myself, the times when I felt the most, kind of like vulnerable and challenged is when I was actually working with clients and supervisees that were coming from the same culture as me, that were also immigrants from Russian-speaking countries. And that brought up a lot of personal stuff. So I just want to acknowledge that when we talk about culture and diversity, we reflect on how do we manage the differences in those relationships, but then also similarities too, because that tends to bring up some personal things for our staff, for our clinicians, and for us as supervisors. And okay, so just doing a quick time check. So this part here, this is really what I got from the staff. When I was preparing for this presentation, I reached out to our interns, our staff, and I said, hey, what do you think? What do you value about supervision? You can talk about the supervision you received here or outside of here. It doesn't have to be about a specific person, but just tell us, what are you really hoping to gain from this experience? What do you value about this? And this feels the most important because that's why we do the work we do, is to support our staff. The feedback that they gave kind of got split into three main themes. They really value an opportunity to learn something new. They want to grow as professionals. They want to sharpen their skills. They want to get better. They want to do better. They want to have something tangible that they can take, they can apply to their clients, tools, skills, interventions, modalities. They're so hungry for that knowledge. And these are direct quotes from the feedback I got from our clinicians. Another theme that emerged is they really want to view supervision as an opportunity to grow personally. So there were a lot of comments that referenced that they want to grow as professionals and as people and as individuals. They say that supervision is something that empowers them. Supervision is a place of guidance. It provides them a chance to reflect. It creates a potential for significant growth, both as a clinician and a person. So while they're growing as professionals, there's this personal growth component that we really must make space for in supervision. And the last theme that emerged is the importance of a trusting relationship with supervisors. They talked about how important it is for them to feel safe with their supervisors so that they can be vulnerable, so that they can admit that maybe I messed up, maybe I made a mistake, maybe I don't know what I'm doing, so that they can do their personal reflections and talk about their own personal experiences, and they can feel safe to learn and to grow. And that makes a lot of sense because from doing clinical work, we know that the therapeutic relationship between a client and their clinician is the most important indicator of success in therapy. It's not the modality, it's not the intervention, it's not even the experience of the clinician, but it's the strength of that therapeutic relationship. So naturally, that relationship becomes really important in clinical supervision as well. And the supervisors, we really need to hold space for all of those learning components. We need to give skills and tools and interventions, and we need to hold them accountable. And we need to create a space of reflection and personal growth. And we need to build trusting relationships. And that is what makes this relationship so unique and tricky and challenging and fun and exciting, and something that I really enjoy doing here. So we went pretty quickly. I'm happy to share more examples and stories about some of the things that we covered, but I know we're kind of at that time limit. So I'm not sure if we have
We
a
don't
time for
have time.
questions. Okay.
Sorry, we don't have time for questions, but thank you for that very comprehensive presentation. It's really nice to learn very in depth what PVPSA is doing to prepare and supervise those in clinical placements. If you do have questions for Olga, just put them in the chat, and then hopefully, Olga, you can monitor the chat and share your contact information there as well. We just have, we're almost at time for our meeting, so we want to make sure we have time to provide some of our Health Workforce Council updates. So again, thank you to both of our presenters today for such engaging presentations. And with that, we're going to quickly move into our last 12 minutes here to provide some updates about our Health Workforce Council. So just a brief recap of our work groups that we've been convening since really the launch of the Health Workforce Council in June 2022. We've got monthly work groups that have been meeting around primary care workforce, our Monterey Bay Community Health Worker Collaborative, and a Santa Cruz County Nursing Workforce Council. Our other work groups this year have switched to meeting more infrequently. So the medical assistant group's been meeting bi-monthly. The surgical tech workforce track, we've established a partnership in connection with Futuro Health. So any employers that are interested in upskilling employees or training in surgical tech are partnering with Futuro Health. And then our integrated Behavioral Health Action Coalition Workforce Group is currently paused, but we're going to get into some updates later in this meeting that will circle back to future plans. So with that, I think Adrienne, are you still with us? We'll have you share some updates about the Monterey Bay Community Health Worker Collaborative.
There I am.
Hi.
Yes, let's see. We had a We Pair Health info session. This is a space for community health workers, promotoras, doulas, and peer support specialists to get support for employment, and then employers to also share their positions. So that actually, Haley put that on for everyone to attend, and where we just want to make sure that there's a portal out there, a space for these unique positions. Also, actually, I forgot the wellness coaches. Yes, and then we had a wonderful presentation from Grant and Matt from UCSC about the important project they have regarding farm worker communities. And I just actually shout out, Grant, I saw you were here today, and I saw that Safe Ag, Safe Schools finally got CDPH to create that portal for spray days. So if you don't know, there's now a place that the California Department of Health Service or Public Health has. It's called spraydays.org, and you can sign up and then get notifications for when pesticides are being applied. So this really, massive project that finally came through. So anyway, that I'm excited about. Yes, our advisory meeting for Cabrillo College is this afternoon. We have lots to share, including the apprenticeship model is really working well for us. We have 18 apprentices in our CHW program. Some are finishing this spring semester, and others are beginning in the fall. So just really hoping for support regarding our recruitment for our program and our courses. And so we have a number of flyers to share that you can put out into your community. And also, if any employers are interested in learning more about the apprenticeship, what that means, and how folks could be part of an apprenticeship program, there's a flyer there in the middle for you all. So thanks so much, and looking forward to our advisory later today. If you want more information about our collaborative or Cabrillo College CHW or CHWs in general, I'll put my contact information in the chat. Thank you.
Hey, thank you, Adrienne. So next slide, we have our medical assisting work group. That work group is our first and only work group that's actually met in person last year, which was really wonderful. So a few of the updates are really geared towards the Cabrillo College MA program for the 2025-2026 academic year. A big change is that they'll only be offering one cohort per year. So they'll start the new program this fall with 30 students, and that program is in the process of being reaccredited with the AAMA that provides the graduating students who qualify with the CMA AAMA credential. And the program is always seeking new healthcare partnerships for externship placements. So if you are interested in having a medical assistant extern, I will put Ashlyn's contact information in the chat, and you can reach out to her directly, and she will follow up with you. Moving on to our next slide, I'm going to let Maria share about our primary care work.
Thank you. Yeah, it looks like Dr. Gordon jumped off, so I'll give a quick overview. So our focus for the past few months has been on capturing clinical immersion programs in the county by survey with medical organizations and information from our schools, and just looking at how we sustain our clinical pipeline development. And from these surveys, we had an 83% success rate in responses. And we're clear, right now we're in the next steps, which are to identify pathway programs that will support these efforts. It was long.
Great, thanks, Maria. So we also have been busy working on our Health Workforce Council report. This is one of our grant deliverables to complete this report by the end of this month, which we've done, yay. So back in 2024, as some of you might recall, Maria and I did a listening tour with about 12 different partners to kind of gauge the effectiveness of our Health Workforce Council and the structure, and then identify some areas in the future that we might focus on. And so this report, which we will release mid-year, is going to have all of the findings from our second listening tour. Also a list of our Health Workforce Council accomplishments to date. There's a lot of good work that's been happening over the last 2 years, and then our sustainability plan. So where do we see HIP's workforce development program focusing on in the future? And then we'll also be looking at plannings to shape future projects and research future funding opportunities, as our current funding ends within about a year. So we'll be releasing all of those ideas and input in the report. So stay tuned for that. And as I mentioned, some of the planning that we've been doing, we can go to our next slide. So one of the things that we have been looking to launch is a Monterey Bay Nursing Clinical Placement Consortium. After Garrett's presentation, I'm now thinking we might want to call it a Nursing Clinical Education Consortium. But we'll be partnering with the Hospital Council of Northern and Central Coast. Joe, are you still with us? I lost my little participant box. Maybe she's left. Okay, she had to leave. So Joe Cafaro will be helping us co-facilitate this as a neutral convener with HIP. We're going to be inviting our local hospitals in the Monterey Bay region. So this is going to be larger than just Santa Cruz County. CSUMB's nursing program, and then all of our Monterey Bay community colleges that have nursing programs. So Cabrillo, Monterey Peninsula College, Hartnell, and Gavilan. And then we have 2 adult learning training programs that may be, developing LVN programs in the future. And so if that happens, they will of course be invited to this consortium as well. And we're really trying to fill the need to bring the region together to have these important conversations around the clinical placement for nurses in our region. So our first meeting is scheduled for June 4th, and we will be establishing kind of the consortia cadence for the future at that meeting. So stay tuned, more exciting updates to come. Next slide, please. Another area that we're in the planning phase is kind of focusing on convening around health career pathways and having HIP be kind of the facilitator and support advocacy for health career pathways, whatever that may look like. And we want to bring in our training program partners such as UC Santa Cruz, Cabrillo College, our adult learning programs, and then also linking them to support service and programs that are currently existing that provide specific support to healthcare career pathways. So Your Futures Our Business, who partnered with us on the Health Career Expo with Cabrillo College, Health Career Connections, which helps underserved students get placed into health internships. Goal and Santa Cruz County Workforce and other, this isn't everybody, right? These are just a few I've identified. So there probably are more, but everybody who's working around supporting students in health career pathways. So we're looking at what we might do to form a committee around that, and then bringing in our healthcare employers, obviously, to join that effort. So stay tuned again, more updates about that coming. And then next slide, please. So just a little note, as I mentioned, Your Futures Our Business partners with us on the Health Career Expo. We also had the opportunity last week to go to their annual luncheon. Here's a few photos of our team at the annual luncheon, and they awarded 31 high school students scholarships specifically for career technical education. So in previous years, I've actually been a scholarship application reviewer, and I was really impressed to see that so many of our local students are interested in pursuing health careers. So these scholarships go to help them with their career goals, whether it's a training program or supplies that they need, or money for college applications, whatever it might be. So it's really wonderful to see 31 high school students got awarded funding to help them support their goals and career pathways. And we will share the slide. So there's a link to YFIOB if you want to learn more about what they do and get engaged with them. They are always seeking guest speakers to join them at the high schools to share about your profession. They also host career expos where your organization could come and table and share with students about what you do in the community or what your health profession role is. So there's a lot of great engagement opportunities with Your Futures Our Business. And then we're just wrapping up. We've got like 1 minute left. So Maria, I'll let you finish us up.
Thank you, Haley. So here's a glimpse into some upcoming events happening in the next few months. The Career College Medical Assisting Advisory Committee meeting is taking place in April. The Central Coast K-16 Regional Collaborative Sub-Region Leadership Retreat is happening in May, which Haley will be attending. And again, the Monterey Bay Nursing Clinical Placement Consortium is set for Wednesday, June 4th. It's also important to highlight that the next Health Workforce Council quarterly meeting will be happening in July instead of June. And here we'll be sharing important updates about HIP's new strategic plan and workforce report. And for that, the date and location is to be determined. And as I close this out, I want to thank you for joining our first virtual Health Workforce Council convening of the year. We also want to close out with exciting news that HIP is restructuring its website. So we will have a new website coming soon. Again, thank you for joining us, and we look forward to having you at the next convening.
Thank you all. We really appreciate our presenters and all your attendees. So take care. Have a great afternoon.